email saying, there you go.
Here it
Perfect.
is.
Thank you. Thank you very much because I got into this because my two of my kids, my 12-year and 5-year-old had migraines. So that's why I got in to what we're doing. So I'm very excited to learn and we have so many of these patients. So thank you.
Very good. So this will be recorded, and it's what, the 15th of October. So I want anybody to be able to watch this. I think anybody can learn, and I'm trying to upload to my own YouTube channel some of this training and how I do it. So what I'm going to try to do is, sort of give a little brief sort of didactic. Interrupt me as you feel like you want to find more information, because sometimes we forget the question at the end. And I think it's important for everybody to learn. And then the other thing I want to do is sort of tell you what I'm going to talk to you about. First of all, I'm going to tell you how I do it. All right. And the technique is not really that hard. And then I'm going to sort of go in sort of how well it works and who to try these blocks on. And then what I'm finding out by doing them. And then what else you sort of learn by doing them that makes you better and managing these patients. And a strategy to use following that would pretty much be logical based on what you can provide for the patients. But we all have a place and a seat at this table, and I need to encourage other folks that are interested in this kind of thing too. People in the area of hormone estrogen research. That's a very important thing, and also diet, also I think, and sleep. And so these are all aspects. But what I'll do is let's go ahead and fire off some videos. I'm going to try to go ahead and share my screen, and then you won't see me anymore, which will be good. And then let's see if we can go ahead and make that happen for you. And I'll just go right on into this. All right. So migraines, they're a hot mess, right? It's a multi-dimensional condition, and it's not fully understood. They're still trying to figure it out, but the brain is sort of the final frontier, right? It's like space. We got so much we still have yet to learn, but we're getting closer as we start putting pieces together. But there's literally so many pieces that not one specialty can really own all this information at a high level. So we need to work together. And this is a condition that, like psychological and other neurological conditions, is literally inside the patient's body. And this one's particularly in the patient's head. So there's not a lot of physical findings. There's not really a clear diagnostic test of migraine. And it's more of a syndrome than just a headache. And the neurologists own this disease, but even they are reluctant to see these patients. In fact, our local hospital sent out an ER email that said, listen, we're too overrun with the migraine patients. You need to send them to your primary care physician. And that's from the neurologist coming from Atrium. And that says something about how many migraines are out there nowadays. It's really changed the game since COVID came along. And I'll touch on that at the end if you're interested. But basically the problem is we need a whole village. It's not just the primary care physicians, which often get this wrong and give patients Z-Paks and prednisone for a sinus infection they don't have. We need the dentist to manage all the dental triggers, and the neck specialist, us ENTs, have been relegated more to just ruling out things that migraines look like: sinus infections, peripheral vestibulopathies, and earaches that they don't have infections in. And so then the gynecologists have to figure out how to manage hormones in a very hot mess environment where estrogen isn't always helpful, but the drop of estrogen is usually the problem. But some patients can't take estrogen because it's basically um, neoplastic poison. They have bad genes that they can't manage, at the risk of organs turning into bad things. And then, of course, psych, sleep, and the gut specialist. But it's a thing that we run into a lot as otolaryngologists, because we see the patients that don't think they have migraines. The neurologists seem to have a leg up on us because they see the patients who do. Our bunches, I got sinus, I got dizzy, and I got these ear infections that keep coming back, and my ear still hurts. The ringing, the phantom smells, the other things that patients don't usually associate with migraines, but you guys play a huge role. Dental pathology, occlusion defects, airway and jaw mechanics, TMD, TMJ arthropathy all can light up the circuit board in our brainstem with pain. And once you start raising that, you start reaching a threshold which you break a seal to cause a migraine. So we need this, because if you can't rest your jaw, or there's a pain coming from something in your teeth that you can't turn off, it's a great trigger. It breaks the seal pretty easy. So we waste a lot of time and resources seeing these patients. The amount of money spent, there was a great program talk that was saw at our academy, said it was somewhere in the billions of dollars spent on maltreatment, misdiagnosis and treatment of migraine. And they think they got sinus, earaches, and vertigo, the ones that see us, but they're not getting better because they get the wrong diagnosis and treatment. And we wind up doing a lot of, CAT scans and endoscopies and testing, and we don't get the right diagnosis because they still think they have a sinus infection. So we're left either playing neurologist or sending them to one. And that's not where our training is rich, using brain medication. And of course, they're not really able to do a lot except for guessing a lot either, but they can guess a lot better. So we know this is not something patients do well. There was a classic study that we studied in our residency training called the SAM study. It was a sinus allergy migraine study. And in 2007, they looked at 100 sinus and allergy patients and had them see ENTs, neurologists, and get CAT scans. And only 3% of these patients had it right. They only had 3% of positive CAT scans, and only 22% of the primary care doctors got it right. And that's because migraines are great Halloween costumes for a sinus infection. We know this from the Summit study because there's a lot of sinus symptoms on these patients: sinus pressure, sinus pain, nasal congestion. But we know this happens, and there's a reason for that because that's what the SPG does. Sphenopalatine ganglion makes it sure feel like sinus because of the parasympathetic firing from that gland, that ganglion when it gets triggered. And so it creates not just symptoms in the nose, which are sinus-like, makes it run, makes it stop up, but it also goes to the eye socket, causes pain there, but also swelling, conjunctival inflammation, ptosis. These patients get a Horner syndrome on that side. And then also the pain's not just on one side, it's in both sides, not just above the eyes, but it's below the eyes, involving the teeth. So the teeth hurt. And that's one of the classic signs that primary care doctors use. Do your teeth hurt? You have a sinus infection, you're getting an antibiotic. But this is the wrong diagnosis, as we just saw. And these are pretty miserable patients too. They're all -3 and -4s, and this is not really something new. But what we know is the International Headache Society classification was basically a research definition that a bunch of guys that thought they knew everything about migraine made a long time ago. And you can see it's sort of a multiple choice question. There's recurring headaches at least 5 times, lasting anywhere from 4 to 72 hours, pretty broad. And then you'd have two of these four things: unilateral locations, not always there; pulsating quality, not always there; moderate to severe pain intensity, here again. Some of these patients have less headache, but more neurologic symptoms, and they're aggravated by, by physical activity and sometimes may worse. And of course, you had this other qualifier of either having one or both of the following: nausea, vomiting, and photophobia and phonophobia, which is sometimes helpful, but not always. And so, and then it's a diagnosis of exclusion anyway, and it's as long as it's not accounted for by another ICD, ICHD3 diagnosis. So what it leaves us with is a relatively narrow and stereotypical diagnosis, sort of like asthma. Asthma has always been dramatized on the TV screens where patient can't get to the ER without their inhaler, they're about to die. With migraines, it's always been that dramatic unilateral headache that made people, that's got to be a bad headache if it's a migraine, and that's how they sort of that's sort of how they qualify it. But what we do know is that they don't always fit the bad headache box, right? A lot of these patients come in with just temporal headache or ear pain, the TMD patients, and they come in with vertigo with less pain. So it's more of a syndrome. Think of it more of a brain cramp when you're thinking about migraine. It's a brain which has accumulated triggers to overcome its homeostatic threshold to trigger an event. And it's not just a headache, it's sort of a whole 3-day event with 4 stages. So like a 3-day rock concert, there's a warm-up band, there's an aura of, hyper-excitable state where the brain's going through this sort of ramp up phase. And that's when you see any sense can have an aura caused by cortical spreading depression. But once it reaches that point, it breaks a seal. Sometimes it may not. You may not have reached the whole headache stage where you have a headache sometimes, and sometimes there's a loss of neurologic function. And that's where you have the inhibition phase, where the brain's in now this relaxed state. And afterwards, there's sort of a postdrome, sort of a hangover. And so this is more than just a headache, right? And what you have to think about is that what happens inside the head, the internal CNS part of it, is complicated. There's genetics involved with ion channels and neurochemical imbalances, and there's acquired disease states, most common of which are trauma and viruses. And then there's the homeostatic deficits that happen just from living life, being busy, and being in a reactive state from having pain. But we know the most common threshold breaker is nociception, coming from nociceptive places in the head and neck, particularly bad noses, bad jaws, and bad necks. And so once it reaches that state, it hyperexcites the brain and causes cortical spreading depression if it's a migraine. But if it's a seizure, it is not much different than that. It goes off the rails and causes synchronized firing. So that's basically the differentiating state, which way it goes. And there's a great resource I would highly recommend, the Association for Migraine Disorders resource, where they have a really good course that Rick Godley put together. That's going to come out with a new version coming out probably pretty soon. And he's got a great video you can watch if you can find this link of the pathophysiology. It's sort of like watching one of these Disney World movies. It's pretty cool. So, so what's a good strategy for managing migraines? Basically, it's really three things. That's what he stressed in that course. Basically, you get the brain's homeostasis right. Hydration, protein, and sleep is pretty simple. And then, of course, avoiding triggers. Neurochemical balancing, and that's the hot mess the neurologists have to do. And then blocks. And that's where we bring some skills to the table. You guys have been doing nerve blocks since you started doing full mouth extractions in the clinic, right? Y'all are pretty good at this. And so then it's not a very difficult extension to doing external blocks because then you're not working in the mouth, you're working in an area where you can actually get the things pretty easy because they're easy targets. The only targets difficult is the SPG, right? Because they're
Mm.
literally below the eyeball and behind the maxilla. But the fourth thing I like to add to this is managing triggers. And that's here again where our neck specialists and our jaw specialists and our nose specialists come in because those are the big triggers. But we need something for hormones. We need something for sight because those can break the seal as well. The whole life happens thing. But blocks really are attractive because they turn off the on button. The problem is, it's not that many people do them, right? Low access, and insurance companies in a way. And people don't like needles, but they sure do like feeling better. And if it would provide a diagnosis at the same time, it's a powerful option, right? So the targets aren't anything that foreign to us. Palatine, anterior ethmoidal nerve areas are things that us otolaryngologists know all the time, and we actually inject them during sinus surgery all the time. We just don't pay attention to what happens afterwards. We're worried about it stopping bleeding during the surgery. But the occipital nerves are really a really important part of these migraine patients' lives. But the problem is, most of us otolaryngologists ignore the back end of the neck, right? That's what our C-spine guys know. We relegate that sort of hot mess to you guys. But the thing is, they're important and they're triggering a lot of the headaches for a lot of these patients the older we get. Because what we do know is we turn into a collection of worn out body parts as we get older, and particularly our neck and our jaws don't get any rest unless we really are mindful about resting. So here's the stars of the show. The anterior ethmoidal nerve, we sort of know about it, but it's oftentimes just sort of left out. It's sort of an afterthought, but it's an easy target. It's literally right underneath the bridge of the nose. So doing external blocks where you're injecting, the supraorbital, supratrochlear nerve, they can be done, but they're painful. The face is sensitive, right? Particularly in the midface. And that's why if you just put a cotton ball inside the nose with lidocaine in the right place, this is an easy play. And in the let me go back one time real quick. The thing about this is so powerful is not just getting the top end of the nose, it's also getting the forehead and the anterior cranial fossa dura. And that's powerful because a lot of the headaches are frontal, right? And that's why it's such an easy target. It's sort of hard to, leave it out. And if you're a nasal doctor that could put cotton and lidocaine right there, imagine how easy that would be to do because we're all wired the same way, right? And then the sphenopalatine ganglion is always the hard one because it's so far back. But that's why I think sphenocasts and catheter techniques in general are a little bit difficult because what you'll find out is they're all the same nose, they're all narrow. And it's hard to actually land the airplane if you can't see where you're going. And the problem is these noses, you'll wind up having a catheter shifted one way or the other because there's a septal spur of the septum so deviated because that's going to be the side they have their headache. And you'll probably wind up squirting a lot of it down the back of the throat. And so you'll miss the target. So the target's really important too, because we know that it's more than just innervating the nose. It's also going to the orbit, it's also going to the maxilla, but also the posterior middle fossa meninges. And also, what makes it sort of the golden goose is because it has sympathetic and parasympathetic fibers passing through it. And to interrupt those things, that's powerful. And then once we turn that pain off, you're taking one of the big fuses and just basically rebooting it. And that reduces the juice at the trigeminal cervical nucleus, which feeds back to all the muscles in the head and neck to higher tone. And so the occipital nerves, our next specialist and you guys are starting to do the blocks there, and I think they're really, really helpful. And sort of, I have an algorithm I sort of use to sort of know where to go with your blocks, and I think that's sort of a thing most of us have sort of figured out by doing a lot of these, and it won't be that much news to you that uses these blocks. A lot of my colleagues find this a little bit foreign, but the whole idea is to create a quiet trigeminal cervical nucleus because that's basically the circuit board. That's the operating center. That's the operators on New Year's Eve that are receiving all these phone calls from pain coming from the back and the front of the head. And the thing about it is when you look at the arrangement of the seats on that school bus back there, they're sort of inversely related. You know, V1 goes at the bottom where C3 goes in, and so it gives you that mirror headache. You know, frontal headache and lesser occipital usually fires at the same time, and your jaw muscles are sort of caught in between. And so this is sort of how it sort of is aligned. They're co-aligned. But what happens when you block this and turn off all the lights in that trigeminal caudate nucleus? That's a powerful thing because neurotransmitters have millisecond half-life. And so what you find, you don't have to turn off the lights very long for everything up and downstream to be sort of rebooted because there's nothing for the thalamus to be juiced by anymore. And that's important because the thalamus just is a release relay center to important things like the reticular activating center, which recruits awareness, the limbic system, emotion, and the cortex, the memory of the pain, and also how it reacts. And so, and the picture of it. And so you get this sort of rebooting of that and the sympathetic tone of the spine. But the thing is, as otolaryngologists, we work in the nose for a living, so it allowed us an opportunity to try to use some of our tools. And this is where we put the cotton pledges. So I decided using cotton and lidocaine because it was cheap and easy. And cheap is the key because what we don't have is a code for this. And so the whole idea is the insurance company won't be able to tell me what to do if I don't charge for it. So the key is knowing the nasal axis of the nose. I'm back up one time. That's important because it goes from the tip of the nose to the sphenoid rostrum, and everything above this goes V1. Everything below this goes V2. And as you know, that's going to follow the teeth, and you can see all these things. You got your greater palatine. That's a great way to get sphenopalatine through the greater palatine foramen, but that might be sort of a hard get, but it's certainly a way to do it. It may be a little less popular than putting a cotton ball in the nose, but certainly a good way that you guys can get good results. And there's actually a good sinus study where they actually compared um, greater palatine foramen injection as opposed to sphenopalatine injection endoscopically, and they actually found that the greater palatine actually had probably a little better results, which is sort of interesting because I think you're a little closer. And I think some patients can actually get, I think the doctors probably can get a little better visualization and feel for that. But this is the algorithm I use, and this is probably one of these sort of things that if you think about it, all makes sense. So I start off, if I suspect a migraine, I start off with an intranasal sphenopalatine block because I'm going to scope them anyway. They all think they may have a sinus infection, and it's going to be helpful to help describe their nasal anatomy and where this is all coming from. But you know, once I've done the scope, sorry, it's on auto advance, the block is going to be free. It's not going to cost them anything, and it'll give them a result of certain things. In about 10 minutes, it answers a lot of questions because sometimes it's not the pain that they're coming to see us for. It's the other stuff. It's the migraine associated symptom they're coming to see, and that'll also go away at the same time. The vertigo is a classic example. But if it's not completely better, usually the brain is still getting pain from somewhere, and the body can tell us that by using physical signs, palpation of where the nerves are located. So if it's still hurting in the back, wherever it's hurting, you do an occipital block. And so once you've sort of turned off all the on buttons and it's still not better, it's probably not coming from outside the head, it's probably coming from within. So that's when the patient needs an MRI and they need their head examined. They need to go see a neurologist. So that way we don't miss a dangerous headache. And that's a really important take home message I tell all my colleagues. So, how I do it. So, it's really not that difficult. And in fact, I think you guys could even land this airplane. Nasal endoscopes aren't difficult to use. In fact, my medical student blocked me. So it can't be that difficult. My physician's assistant blocks me. So these aren't asking anybody to operate a sphenoid sinus. We're just trying to put cotton in the nose. And I've got an idea about maybe avoid using little cotton balls. And you can use cotton balls with strings, what have you. But it's very simple. Basically, use atomized lidocaine and Afrin. Now you can use um, ponticaine or tetracaine, or you can use neosynephrine. It probably doesn't matter. You're going to wait. You're just doing that to prep the nose a little bit. So the nose is now open and numb. And then what you do is use that time wisely, because the biggest impediment to doing this is not that it works, it's finding the time to do it and the time to explain it. So you have to use props and be organized. So I always have a method. I check the occipitals, the pterygoids, and the V1 and V2 locations by palpation. Nerves that are hot have a lower firing threshold to mild to moderate pressure, and the patient has it controls the other nerve on the other side, and a place that shouldn't have any sensation, their scalp. And so you can always find which points are hot, and the patient will tell you. It's pretty easy. Two, you give them some literature. I got some good stuff they can read that they can sort of understand what they're doing. And then you just use small pieces of lidocaine soaked pledgets that you put in the kidney basin and lay on a gauze so they can sort of dry out a little bit so you're not putting a sloppy wet one in the nose. And then I give the patient a lollipop so they don't have the taste of lidocaine and also the drama of feeling a numb throat. But if you allow them to sort of sit on a gauze for about a minute, they don't really get that. And then I use a camera system, but the camera system doesn't have to be something expensive like this Telepack. Telepack is an expensive thing that proprietary companies have come up with for otolaryngologists that probably cost about 10 times the amount it should. So one of my colleagues found a way to do this on the less expensive. He uses a laptop, a camera he got on Amazon. Um, these scopes you can get probably three zero scopes on AliExpress for probably $110. I priced them out, and and then you just use have a couple of screens, one on your wall and one for you to look at. So then you can just land this just like I do in my office, and I can show you my setup with some pictures if you want me to. But it's not difficult. I'm encouraging for everybody to be able to use it. The problem is, I don't know if non-otolaryngologists will get covered by insurance to do nasal endoscopy, because nasal endoscopy itself reimburses. Doesn't matter if you have Medicaid, and it doesn't require a pre-certification. So I can do it on the fly on every patient I suspect a migraine without having to worry about whether the insurance company is going to reimburse me, because I'm getting reimbursed pretty reasonably by doing nasal endo, regional rigid nasal endo. Reimburses anywhere from 250 to maybe $400, and so it's not Medicaid, probably not that much, but it's not a bad reimbursement. It's not super lucrative, but it's worth it because you get answers and you get the
So
patient better.
Mark, so
So
Mark,
these are the
you,
points.
so Mark, you anatomize the lidocaine, and then you put pledgets on top of that before you scope.
Right. So what
Okay.
I do is you can use an atomizer. You could use an atomizer that's just like a perfume atomizer in a sense. They make these. I'm sorry, I may pause this for a second. And so all you're gonna have one with lidocaine, one with Afrin, or you could just have a combination, half and half of one bottle. You can spray it up the nose and just wait 5 minutes, and then now you have an opportunity to place pledgets in there where the nose is going to be more open and more accessible to not being exact, right? So if you're doing this without a scope, it's hard, but it's not a lot easier when the nose isn't sensitive and it's more open. But these are the points I assess: the supratrochlear, supraorbital area, infraorbital, the insertion point, the medial pterygoid, and the lesser and greater occipital areas, which is easy to find. The 1/3 and 2/3 point between the mastoid tip and the nuchal tuberosity. And so these are the points I'll always palpate, and I'll have this picture for the patients to take home, and I circle where they're hot, because then they know where their homework lies. Wherever you had to block is where the nerve is entrapped by mad muscles in the neck, and if it's up front, it tells you what part of the nose is really where the problem is. But if it's up front, the nose needs air. It's usually a tight shoe effect, essentially, pressure receptors that are being stimulated by pressure from inflammation in a tight nose. And you'll find these are all the same noses. They're all narrow noses. So you educate, you teach them about this process as you're doing this. And then, your assistant can easily set aside a bunch of these in the morning so you'll have them ready for you. And this isn't difficult to do. And this is the size of the alligator I use. It's like kind of want to use for a pee tube on a kid that's getting a tube placed in the office. And this is a patient information handout. And use a QR code for it up there. And of course, I can just send you a copy. This is not difficult. It just tells you what you're doing, how we do it, and what the risks are. Very minimal. Basically, the risk of allergy to lidocaine or Afrin, which is going to be demonstrated when you spray them to begin with, and so you won't go any further. But that's extremely rare, as you know. And then the other risk of swallowing a cotton ball. So American Surgical makes these little cotton balls with strings on it. So you can probably just no, not that many people want these because they want strings hanging out their nose anyway. But you'll have them available, and I haven't even gone through all the samples I got from them. I don't use it that often, but honestly, these patients aren't that numb in their throat that they can't protect. And so, because I get these done on myself, I mean, you can feel everything. And in fact, it's not really that much in the back of the throat if you use one that's sort of wrung out. And then I just, basically give them just so it's sort of an informed consent in a sense. And then this is another, I have like a little laminated thing, which basically shows them where I'm putting the cotton. And this is one of my pictures I have. And it's basically the target I use is 2 pledgets up front and 1 in the back, really, because the nose, okay, the nose up front here, it's as an easy play because that's easy to get to. So you might as well nail it good. Because when you start blocking up front, that's going to start working. And so even if you can't get the posterior cotton ball in the back, it's sort of already pretty numb by the time at the end of 10 minutes that you can reposition it. And I got a little video here too I can show you. So place it right up high in the nasal vault. You'll put it right there between the middle turbinate and the septum. And then it'll just sit there, and then you'll get a second one in there too, so you can really nail it well. And the sphenopalatine, you're going to ride the top of the inferior turbinate between the septum and the middle turbinate, and just sort of you'll push it back and just till you feel some mild resistance because it's not anything that should be particularly noxious. It's because it's just a piece of cotton, and then it'll sit there and then till the end. And if you're not quite back there because it hit a spur, and you'll sort of know because you can get that far. Once you get to the end, the nose is basically cadaveric because now you've turned off the sympathetic and parasympathetic tone, and so you get a chance to basically hit a two putt. This is like a dog leg for those patients. You can't see where the ball went. But if you're that there, you can chip it in because now the nose is numb and more open. And so you have access now with your scope. And this is not that difficult, guys. You can, if you can do some of the stuff you guys do, certainly this is not that difficult. So my whole idea is I don't think us otolaryngologists need to own this. The problem is I don't know because there's too many of these patients to go around. So I just want this to get out there and I don't care who does it. The bottom line is they need these because it really gives us the answers that we need really quick. Because in 10 minutes, if it's not better, it's either the pledgets aren't where they're supposed to be or occipitals are playing a role. And so if the headache's not all the way gone, you check your cotton location and your patient will tell you. If they're still sensitive in V1, you check your AE pledgets. If they're sensitive in V2, then they're probably the sphenopalatine either got you have a jumper, you swallowed the cotton ball, or you got one that's just not quite there yet. And then you can just usually get it there. And it's usually within 30 to 60 seconds, these patients' headache completely gets better. I had one of these today, just exactly like that. She said, I'm still hurting over the temple. And sure enough, she had a spur. And where I landed the cotton ball in the first try was right over the spur. And so what I did is once I got her numb and pretty open at 10 minutes, I just moved the cotton ball a little bit further back and put another one in there. And within 30 seconds, her headache went away. It's pretty impressive. Now, the occipitals play a huge role in these patients. So at least 25% of these patients, probably a little more than that, probably need occipitals to really get a good block. And they'll be tender in that location, and they'll show two things. One, their pain will go away, but also the range of motion will immediately get better. So I usually have them do a right and left turn to see how limited they are by their rotation. And if the rotation, I'll document where they're at. So they get 60 degrees on this side, 45 on the other side. 45 is usually the side they're sleeping on because that's the side that's usually more strained, and that will be much, much better afterwards. And then you can see what's left. And I'll tell you what kind of disc pathology they have, or the lower part of the neck's playing a role. But as you know, at least 50% of the rotation happens, at the top part of the neck, C1, C2. But if not any better, get a neurology referral. MRI, I can do CTs in my office, so I can at least evaluate the sinuses, but it doesn't show anything about the brain. And the MRI is going to show the brain too. So, and even if they do get better, just don't let your spidey sense go down and miss a dangerous headache. I implore everybody that does headache work to do that. So this is my diagram on occipital blocks. How I do it is I don't use steroids. I started to begin with, but I stopped doing it because I don't want to worry about dermal atrophy or any steroid side effects because I didn't really think it added that much. So I just use lidocaine. I don't use any epinephrine, but I do buffer it with bicarbonate, 1 to 10 dilution, and I use a 30 to gauge needle because I think the whole idea is to not inflict pain in any way. because they're already lit up and they're already sensitized to pain. And so what you do is use something as least offensive as possible. So you use buffer lidocaine basically like you're numbing up somebody for an IV, just creating a little wheel there, just, and subcutaneous, a little deeper, so you can have a numb corridor to go through with a slightly bigger needle, 25 gauge needle, so you can fire in your bupivacaine. And the concentration is less important than just getting it where it needs to be. And you don't need to be right on top of the nerve. You can just sort of go to the right and left of it, because it's going to get in the subgaleal plane where it's going to spread like a drop of water on a mirror, and it's going to get the nerve really easy. This is really forgiving. This is definitely horseshoes and hand grenade stuff. And when you find these points, they're easy to tell you whether they're hurting or not. You don't need a lot of pressure. And so I usually do anywhere from 3/4 to a whole cc. And so you're not worried about local anesthesia toxicity situations when you're using this small amount of even Marcaine. And so your whole idea is you're trying to create a silent trigeminal caudate nucleus. And this point, just to reiterate, that's why I put slide on here again, because these are the three things. Neurotransmitters have millisecond half-life. That's powerful. Two, there's pathway convergence. And so we need to realize that sometimes where the pain starts, usually where it originates, but it may not be where it winds up, because migraine spread like a fire. It's like a mad toddler on a school bus that wakes up the whole bus. And so it starts to increase that because of what CGRP does to the activation of pain. And then glutamate levels go up, which also works on that. But then the reboot that happens when you start to reset these important pathways, sorry about the typo there, is that brainstem and thalamus, sympathetic and spinal pathways all rebooted. And that's a very powerful thing. Because once you do that, basically all the nociception from the head and neck is turned off. And that's a powerful thing to do because of its neurochemical effects on serotonin. It brings your serotonin up immediately. There's not too many things that do that. And it brings down your central sympathetic and adrenergic and glutamatergic tone down. So the patients are, less anxious and less triggered and less painful. So we see a lot of this stuff, and it's not just sinus, vertigo, and ear pain. We see all these odd auditory symptoms, transient tinnitus. Patients come in, say they can't hear during their headaches. I'll block them. They'll start hearing. It used to be, I think, probably auditory processing, but a lot of these auditory processing disorder patients probably have either ADHD or migraine or both. Hyperacusis. There's these patients will come in and say they have drainage in the ear. There's nothing there, something crawling in there, and it's just an aura. And that, oh yeah, that went away when you did the block. Okay, that's what it is. And then the myoclonus, a lot of myoclonic symptoms get better with this. Myoclonic palate, myoclonic stapedius and tensor tympani muscles, they're just dysregulated, and that's what this does. It allows that sort of bandwidth hog taken up by pain at the midbrain to be turned off. So everything that needs fast processing speed can now reboot and get that processing speed back so you can modulate things. And the same thing with olfactory symptoms. We see a lot of these post-COVID patients coming in with phantom smells. They're coming in thinking they have a sinus infection or something like rotting in there, a tumor, because a lot of these are mal smells and bad smells. And so I'll block them. But what will happen is also their low level of resting smell olfaction will actually come back to the surface. It won't be robust because it takes at least 95% of your olfaction to be basically messed up for you to have loss of smell at a symptomatic level. So, and it's because of the anoxia of the glial cells. That was the target for COVID. And, basically it just takes away this injury current and allows it to not dominate. And so what resting low level of olfaction will now raise to the surface. And that's the way a lot of these things work. And then vascular symptoms. We see a lot of hemifacial symptoms on the side of the headache. They'll be red on that side. They say their face is swollen. It looks fine to me, but then I'll block and they say, you look better. Oh yeah, they got better too. And the red ear I used to see all the time. I wonder if it's relapsing polychondritis. Now I know what it is. That goes away. And then there's dysautonomic symptoms, hyperemesis. The POTS patients get better. The patients with GI migraine, supposedly, these all are the same patients. They're all the same patient that was motion sick growing up. Same patient that probably had colic. The childhood manifestations of migraine are very interesting. And it turns out motion sickness and migraine run by the same pathways, and they're probably the same people. So patients that come off a boat, they have mild day embarkment syndrome. I block them and they're better. So it's pretty interesting stuff, and it's a very valuable tool. And so, I'll tell you a little bit about what I found out because I'm going to share some experience. This is preprint data, but it is important because I think this is important enough to know for conversational, since it's not peer reviewed, it's purely for conversation. But when this is impressive, you want to share it. So what we wanted to find out when we did this study is about who to target, who these patients were and how they're presenting, and how good it was, how good it was effectively acute basis, and how long it lasted. So we did a pilot study, and we did about 161 patients, and between February 21 and 22, and the demographics were largely female, but a lot older than your typical migraine cohort. And that's because these were a lot of long COVID patients. It turns out long COVID, their average age is in the mid 50s, whereas the average age of migraine patients are usually between 25 and 50. So, but they were definitely female. So it's sort of a hybrid. And these were significantly bothered patients. They had significant frequency and severity, and 50% of these patients had never had migraine diagnosis or migraine treatment. So these are migraine naive patients. So patients that never had migraines before having migraines. And that's what COVID did to us. And that's why I started doing this. And I became one of the patients. So I became very interested in this. And when I found out, it's only 25% came in for a headache. They mainly came in for sinus vertigo and ear pain. And here's the statistics. Pretty interesting. A lot of tinnitus too. See, look at all that ear pain, jaw pain there. A lot of TMD. It's because it's loaded up with ACE2 receptors and CGRP receptors. And I'll tell you more about that if you're interested. But then we looked at more information because we lost some data on that because our IT department's a bunch of knuckleheads and they depleted the raw data on my medical students' account when they did just their routine 90-day maintenance. But anyway, I learned something, been doing that. First of all, back up everything and also how to do this a little better. So we actually rephrase some of our questionnaires and chart data to actually ask the questions better. But we did 3 phases because COVID was playing a big difference in this. And COVID Classic had a much different imprint on these patients than the later variants. And so we had 3 different phases. And the last phase was basically much more questions using a questionnaire, which made it a lot more patient friendly. And so we were doing these while the patient's sitting there blocking. They would just fill out the questionnaire while they're sitting there marinating. And so we got some good information, and I'll share that with you. So very briefly, became increasingly female as we started seeing this go on because I was getting more migraine patients referred to me. And then they were increasingly younger. Here again, more migraine patients. And as things evolved, we found out this really worked. This is the numbers. You're talking about the pilot study was about 73% SPGs work, but now we're up around 87% because we're learning how to do this better. And the tricks I'm teaching you is going to allow us to be a very vertical learning curve. These patients basically, if you can improve their lie and use your palpation of points, you can actually be a lot more accurate. And if you add on occipital blocks, it's embarrassingly good. And this is an N of 309. That's pretty nice. And so then you have average duration 15 weeks. And then block by type, if you did just a nasal block, it was about 14 and a half weeks. That's up from 13 and a half in my pilot study. And occipitals made it around 17 weeks. And the second block adds duration. You see these patients probably last a month more on average. And so as we started working through the data, as you saw more headache patients came in, but you still saw the usual suspects right behind them: the dizzies, the ear pains, the sinus, the tinnitus, the facial pain, the dysosmia, and the neck pain. But their second symptoms was dominated by ear and neck pain, and a lot of auditory symptoms, and a lot of sleep symptoms. And then the associated symptoms, if you asked them what else was going on, all the symptoms of having a slow processing speed were quite evident, and their triggers were evident. Brain fog, bad necks, bad jaws, and bad noses. Vestibular and auditory symptoms frequent. Here again, slow processing speed, and hormones and exaggerated orthostasis in these patients was also quite frequent. And the triggers, here again, number one here's our neck guy, neck pain. Allergies are things that make the nose mad. Number 2, barometric pressure. We can't hide from tropical systems. And every time one came through, these patients were coming to see all of us, right? By the truckload. And TMD, emotional stress, eye strain, the usual suspects. And what I did is actually looked at what people were doing for this. And it's very primitive. I mean, it was basically NSAIDs and goody powders. We're in South Carolina. Primary care physician was doing the work, and relaxation techniques is the best they could do because they didn't have, they had migraines. They were just trying to just chill out, probably doing gummies. But anyway, so there's a HIT6 disability index on these patients. They were miserable. Yeah. And so we need something that really works. And so this is what I found out in terms of duration. Here's the numbers, actually. 15 weeks on average on their initial block, second block, almost 18 weeks. And then the occipitals add 15% and about 17% duration. So that is nice. So these are the four groups that usually emerged. You had the ones that lasted about a week and they work because they work longer than the local, but they didn't work long because they have bad problems and they're probably not the best patients. And then the ones that have better relief usually either do the homework a little better and they're not as quite as severe. But the ones that lasted over a month were usually the patients that were pretty happy campers. They were the ones that were actually younger, less severe, less chronic, and that would make sense because those are usually the easier ones to treat for all of us, right? But this made it a really nice modality because if it lasted over 3 months, that's on par with Botox, and you don't have to worry about a pre-cert. And so those are the patients will come back. And so what I did is I dedicated just a special migraine clinic, and they can just go in through the portal and tell me what they need, so they can know what they need to get. And we just can get it ready for them. They just come in, and you can use your. I use my extender. I mean, my PA can do a lot of these because these aren't hard. And of course, he gets to practice on me, which is nice. And then the ones that are short responders, and they know who they are and they know why, usually the ones that are living like a rock and roll star. They're smoking, drinking, missing meals, and not sleeping. And they have bad triggers. They have bad noses that need to be fixed. They have bad jaws and they have bad necks. And they have sleep problems. These patients are insomniacs. They work night shift, or they aren't wearing their CPAP machine, or they won't wear their night guards. And then here again, neurochemistry. And a lot of times they're not on the right meds and following up on that stuff too. But these patients also, you need to think imaging and definitely get the colleagues that need to manage the triggers that I'm working on so we can sort of work together as a team. So once you get this, it's a great toy, guys. I mean, you guys know the blocks work and they really help. Sometimes it's a little bit of a hard sell because not every patient wants, injections, but this one here, because it works so well, it's relatively not, you know, painful. It's a really good one because it does three things. It establishes a neural process, migraine or something like that. Two, it also explains that the other symptoms, which is often the issue they came in for, went away too, is probably due to that, especially if it stays away. And then third, it locates where it's coming from based on where the nociception's at. So it tells you where to work on as homework. And so it's quick, easy, safe, and effective. So why not? So, so what you discover in seeing these patients are all the same noses. I call this the nasal epiphany. The nose basically will be the narrow nose with a crowded side. And the crowded side is the side where their headaches are, up front and in the back and on the side, because that's the side they're going to sleep on. But it's also inside the nose. What's going on is these are high pressure zones. It's not contact points. The whole side of the nose could be lit up from top to bottom, getting a V1, V2 distribution. And it's because we know this is the way the nose is wired. It's loaded with pressure receptors, and that's usually triggered by things that make the nose mad. Allergens, irritants, and infections. And what that does is it depolarizes the non-myelinated C fibers, which are directly bound to the receptors, and that creates a release of CGRP, substance P, and a bunch of other stuff. But basically, the CGRP is what's really causing the problem because that sort of rallies the troops. It's an acute phase reactant that turns on neuroinflammation. And what we don't have a good tool for is for neuroinflammation. CGRP inhibitors are helpful and they're getting closer to the front line, but something to establish a good reboot of this is going to turn off the CGRP because basically it's going to be turned off of why it exists, right? Because it's going to cause neurovascular and inflammatory components of the reaction to when that pain starts. And it primes the brainstem to do it too. And so treating the nose is imperative. Saline rinses with nasal steroids, treat the allergies, chronic sinusitis if present, and nasal surgery if it makes sense. And it seems to be logical. But what you find is when you look at these patients, why they hurt on that same side and their jaw and their neck is because they're sleeping on that side. And so patients will generally sleep with their bad side down. And you can look at their jaw length and their hyoid height and their nasal airway, and you can tell a lot about how they live. They'll sleep with their bad side down because blood goes to the bad side and turbinates are venous sinusoids. And so gravity dependent. And so it doesn't take a lot of swelling to stop up the bad side, but the bad side they're not using much anyway. So if they sleep with that side down, they're not struggling to breathe. But if they sleep with the good side down, that's the only good side they have because on their back they can't sleep well because their tongue falls in their airway. So when you sleep at night, the rule is you're going to sleep where you're going to rest the best, and you're going to rest the best where you breathe the easiest. Because least work of breathing means the easiest sleep. The only thing that trumps this is bed partners and pain. And so then those patients that are hurting on that side from sleeping on that side wind up ping ponging. They hurt and they roll on that side, and then they can't breathe and they roll back, or they get elbowed by their bed partner. And so that's what happens. It controls the dynamics, and it doesn't take a lot to improve this because we know this. We know Pascal's law is radius to the fourth power. And so if we take nasal airways and improve them a little bit, we improve flow a lot. And so the jaws are sort of a slave to this whole process because they're just working their tail off to keep the airway open while the nose doesn't work. So the jaws, the pterygoids are pushing the jaw forward to get that pain going on in the ear because we know that's what it does. And then we hold on with the masseter and temporalis. This is stuff you guys do. And so I'm telling you what you guys are probably can correct me on anything I don't understand about this, but it seems like it makes perfect sense to me. And that's why they hurt so bad. They got mad muscles of fatigue, particularly those pterygoids, because they're putting a vice grip between the mandible and the pterygoid plates between two bones, and it's doing pull-ups all night long, every breath they take. So no wonder it hurts. You squeeze your biceps tendon when you're doing pull-ups. It's painful after you've done 10 of them. And that's the same thing's happening, but it just doesn't stop. It just keeps on going on the same side every night. And then the same thing's happening to their neck. Clearly if they have a short mandible, obviously now their tongue's got a small cage and it's huge because it's doing sit-ups against their palate all night long. And so they have a huge tongue and their mouth's open and they're drooling on their pillow and they probably have pretty bad sleep apnea. And so I just love this whole anterior biplane splinting thing. The problem is sometimes patients don't wear them or they're made well or worn right. And of course, sometimes they just chew on them. And sometimes it distracts their joint space because they're pulling it forward. Now they have a wide space and then they get the joint issue. So that's why you guys have a big challenge. This is not always an easy thing to fix. And so we need you guys on that wall. So I'm so thankful that you guys are here because I want to learn from you guys more about these parts. Now the neck here again is a slave to the head too, and this SCM and also the infra obliquus, on C2, those things are going to trap this occipital nerve plexus, but it's that side sleeping pattern that causes the SCM not to get enough support on the pillow. It gets tight and it's pulling on your lesser occipital nerve. It creates that behind the ear pain, and then the ones that can't get their shoulder out from around their pillow, they're pulling on the trap, and of course their eyes are in front of their head and their hands are below their eyes. And so they're always looking down at things too. So the combination of forward head posture and looking down at things traps that greater occipital and the tendon. There's a little hole in the tendon, and it's obviously if it pulls down, it's pulling on a nerve, and you pull on a nerve that can't move because it's stuck in the scalp. You're going to lower spiring threshold, which increases pain triggering, and which makes the muscle trigger more tightness. And so it becomes a vicious cycle between the muscle and the nerve. And so blocking that by using local anesthetic is a powerful thing to sort of just break the bad loop. And so what you find is migraines is just a series of pain loops that, we just need to be able to sort of reboot. And it makes sense. I mean, we control delete the computer when it's fouling up. It's the first thing we do. We don't change the hard drive or reprogram the computer. We just hit control delete. And so, what about the nose? And I'll hit this very briefly because this is not the point of what our talk is about. But fixing the nose seems to work, and that makes sense because you're addressing the point of nociception, a tight, narrow nose, by taking the septum and making it thinner underneath the nasal bones. You don't have to have the bone under the nasal bones to provide support because the bones themselves do it. But making the septum thinner and straighter is one key, and the other is also making the turbinate small enough so there's good room for laminar flow and less likelihood for pressure to be created to create that triggering. And then the other things that happen indirectly is you improve sleep quality and you address the major reason why they're always sleeping on that same side every night and working their neck and jaw. And so those are all three powerful things and they all make a lot of sense. And so the concepts I've learned from doing this a lot is that the nasal anatomy tells a story and that every sense can have an aura or functional loss. And that neurologic slowing does this. It's the cortical spreading depression that does that. It causes the brain fog. Balance is basically a video game, right? And so you need a fast computer to run a video game. And if you slow your processing speed, things like balance and remembering things and thought process break down. And of course, also, the reticular activating system is amped up during migraine, so there's sensory hypersensitivity. But the slowing of the processing speed, in order to ignore a stimulus you don't want to notice, you actually have to be able to react to it almost instantaneously. And when you can't react fast enough, you can't suppress it. And so what happens is things like tinnitus gets dysregulated, light sensitivity, sound sensitivity, motion sensitivity, all the senses become extra. And SPG blocks are very powerful because they sort of reboot not only these pain loops, but also allow, there's really good data on this. Cool stuff that the bump in the serotonin and the drop in CGRP and nitric oxide that happens with doing an SPG block is powerful. And you don't know this until you actually feel one yourself. The feeling of calm you get after these things is really impressive, particularly if you add on the occipitals. Because if you create a nociceptive quiet state, that feeling of calm, you can't really describe it until you've actually had one done. And what this does is it really counteracts exactly what happens when you have an estrogen drop, either in that luteal phase of the menstrual cycle or during the premenopausal periods. We'll see this will counteract PMD and premenopausal hot flash symptoms. A lot of my patients, I don't advertise this because I didn't go into otolaryngology to have those patients, but they get better too. And then, the older patients, this is impressive. A lot of these patients will come in with dizzies, but they won't have much pain. They'll basically just have a little stiff neck because their pain tolerance is better. Because you'll know there's a neurology truism. As we get older, mild or moderate pain, we are more tolerant to as we get older. It's probably sort of an evolutionary and neurologic wearing out component of these things. We don't understand that. We all have a sensitivity to severe pain. Everybody knows what a gunshot wound hurts, but the thing is, as you get older, if you have severe pain, you're less tolerant of it once you get there. But the patients that come in with the dizzies, the older ones typically have a lot of neck pain, but not a lot of other. And so the dizziness patients, most of them I've seen nowadays are migraine of some kind of variant. Turns out that BPPV and Meniere's disease are just part of the same Venn diagram. They seem to have an interplay. And then there's two basic patterns of this. There's a baseline intolerance to vestibular challenge and discrete episodes when you actually have the episode of a migraine. And then ear pain is TMD is the most common cause. And in these patients, the first thing I'll do is look in their ear and then feel behind their jaw. And that tells me everything. Neck pain is often the reason for the SPG failures. They are all symptoms that they're transient, think migraine, smell disorders. I try blocks on these patients. Not something y'all are going to be doing, but it's interesting. And then try it for other things. Pretty much all of the facial pain syndromes respond to this. Neuropathies, neuralgias, trigeminal, postherpetic, they all work. I've seen benign essential tremor improve with this. That's very interesting. Brain fog, obviously, that's why I do it for myself. Anxiety, I do it before I give my talk, so I didn't do one tonight, but it keeps me from stuttering actually. Motion sickness, Malday embarkment syndrome, and even the hot flashes possibly. Don't tell anybody. But anyway, here's the things I've found that work well in my clinic. Even this whole tension headache thing, is it just the efferent loop of a migraine? And that's sort of my opinion on this. It's just the out loop. And so these are my conclusions. Migraines imitate ENT conditions, particularly sinus balance and ear conditions. Two, these are really effective, especially when combined with occipital blocks. And as such, they're so effective, they can be used in a diagnostic modality. And finally, the advantages of being able to use scopes and getting comfortable doing this allows you precision and the skill. You don't have to be a sinus surgeon. I put that on there for my ENT audience, but this isn't that complicated. We're not taking out a pituitary here. We're just putting cotton balls in the right place. And you bypass your access barriers because you don't have to worry about the pre-cert if you're us. And I haven't tried to see if one of my neurologists could put in a code for me. I thought about just having one of them just try to bill me for doing this and just to see if it would go through and not charge me for it. And then non-invasive, no injection, less lidocaine. I measure the amount of lidocaine in the cotton balls. I actually did that, 2 milligrams. And then low cost, just cotton and lidocaine, nasal endoscopes, which we can get for not expensive anymore. So this is a good thing. And so if you have any questions, you can ask my favorite migraine trigger, my daughter, and this was her Christmas picture at school, and I made it into a mugshot. And then some videos that you can find, training videos. The self-block technique my medical student did is excellent. And I found the best thing to do self-blocks with, I think, is a little pediatric safety Q-tips because they're fuzzy, they really absorb well, and they fit comfortably in a nose. And here's the migraine resources at our academy. Rick Godley is a star. He came up with all these tools. The migraine resources on the AMD website are fantastic, and they're all free. You can put posters on your wall, and that's basically it. So let me stop here, and then let's talk.
So
Mark, absolutely amazing.
absolutely.
Yeah, I mean, this has really given us a lot to think about, and this is really kind of showing us how cohesive our fields are. I'm already thinking of a paradigm of like doing a lot of these, and then if the neck is still, if these symptoms don't go away, then Dr. Bearder can hit up the neck and address that. And what a great way to just concisely put it all together. Then you can spend hours with us and just do the neuroanatomy, and I want to hear you next time talk more about the relationship with COVID that you explained to me briefly with our time together. I know a couple of us have to go to a Dr. Spencer webinar tonight and jump in a little bit late. But I thought that was absolutely amazing and very inspiring. It tells us we have a lot to kind of keep our mind open to, and maybe a lot.
I didn't realize there was a conflict going on. I apologize for that.
No, that's
I may
okay.
have
I
gone.
mentioned it. Yeah.
I have a quick question for you, Dr. Abram. I'm trying to understand the biochemical reaction where a drop in what did you say, the nitric oxide? If
Yeah.
you do
So
the SPG block, you're gonna get that drop in nitric oxide. Is that
central nitric oxide, not in the sinus. So the neurochemistry that happens when you upregulate pain at the brainstem level is you get low serotonin, high glutamate, high adrenergic tone, high CGRP, high nitric oxide, high substance P. And so you get all these things there. And so these are all things that we don't have really good ways of toggling and modulating. So imagine if you could do something that powerful quickly and what it would do for not just pain, but for neuropsych stuff. That's where this is really compelling to me. Imagine if you could get something from Walmart, you could squeeze in your nose and look at the ceiling, or to get lidocaine from good pharmacy, which is what I do in town. I got a pharmacist that I made nice with that she can give me this topical lidocaine I can send home with my patients. They can take Q-tips, stick in the nose, look at the ceiling, and if it's not only better, take a Nurtec, and they're good. And it's amazing what it does. That's how I block myself. And what it does for neuroinflammation is powerful. And this is where I think it was really interesting myself because I really truly had a sinus infection 2 weeks ago, but I had a migraine too. And it's because there's nothing quite like a sinus infection or upper respiratory tract infection that triggers targets the nose to trigger a migraine because of what it does with not only just pressure receptors, but upregulating all the cytokines involved with inflammation. And what happened with COVID was basically innate inflammation of priming, which was really interesting. But what happens is we don't have good means of turning off neuroinflammation. And that's not something people talk about much. They talk about, humoral immunity, they talk about, T cell immunity, but what they don't talk about is neuroimmunity. And neuroimmunity is one of the oldest branches of our immune system there is. And we have basically CGRP inhibitors. That's about all we got because that's what they sort of do, because CGRP is sort of the neuroinflammatory quarterback of the body. But what it does is it allows us to bypass using a medication because medications always have side effects and have costs and have barriers. But when you can do something as cheap as using lidocaine to basically reboot these very powerful things, and what happens when you do that at a brainstem level, it's just so powerful. So the feeling of calm, and that's where I really am compelled for this. I think psych and cardiology probably have an ability to use this, and they don't realize it because tachyarrhythmias, the POTS patients, it's impressive because you're basically turning down their central norepinephrine level, which there's really good data on SPG blocks. There's some pretty good studies where there was a blood pressure study where it was like 60, it was like 2/3 of the patients had a 30% drop in their blood pressure by central means. Now it fell out. The blood pressure is so multifactorial, so there is always need for more with that. But talk about what that does for bringing down heart rate with these tachyarrhythmia patients. And the thing is, with the POTS patients, what's happening is they're just dysregulated. Their central nervous system at the brainstem level and the hypothalamus is dysregulated. So when you can reboot that without, because we're getting up there and doing anything about that is not easy. I mean, clonidine does some work, but it's not really what we want to do. Because here again, side effects, right? Rebound
Right.
headaches.
I've had a lot of success with just using the sphenocath and making sure I get it down with 2% viscous lidocaine, and I get amazing results. So with these little cotton plungets, the anterior part, could we not just use viscous lidocaine on a cotton tip applicator and just put it in the
Absolutely. You know,
and
my
dually
way's
do
not the
that?
only way.
No,
Right.
no,
My
I
way's not the
mean,
only way. I found something extra interesting recently, just 2 days ago. American Surgical, I was just going through their catalog. They have these little cottonoids with a string on it. They're shaped like flags and they're really thin. And so what you could do is just say, take a bayonet and just soak it in the stuff and just place it up in there, just leave it there for 10 minutes, go see another patient.
yeah.
Talk about how cheap that would be.
Oh yeah,
Forget the sphenocin.
I have a woman that's been seeing a neurologist for 10 years, and she had a migraine for 3 months. I did a SPG block with the sphenocath. She still has not got another migraine and I think it's been a year now. And she went to the neurologist and she's like, "How come you haven't done this on me?" He goes, "Oh, that can work. But, we use needles and this and that. I just use the sphenocath, no contraindications, and in less than 10 minutes, it was gone. But
And it's a great technique.
yeah, and my question was, if you have a decrease in nitric oxide, then you're going to have less vasodilation. Is that the mechanism of what decreases the migraine because you have less vasodilation?
Yeah, nitric oxide is multifactorial in how it's working,
Right.
but in the vessels, a huge vasodilator, and the whole idea is you're vasodilating, the meningeal vessels, causing stretching and causing, release of histamine from mast cells and all this other stuff
Okay.
that goes on, which here again is a hot mess. And so, we're trying to do the thing is, as you look even at this at the serotonin receptors on the vessels, there's so many different types, and that's why it's so hard to actually get good results because you know what may work for one may not work for other. That's why they had different G-pants for the different receptors here again. That's why they came up with the ditans, less side effects from the triptans, trying to get that golden goose in terms of a really good medication. But if anybody's tried Imitrex in this group, that's not fun medicine to take.
Mm.
CGRP inhibitors, G-pants, that's nothing. That's like taking a sugar pill, and it works, but it doesn't work for the bad ones because all you're doing is turning off the trigeminal, caudate nucleus's
Yeah.
activation and activation peripherally, which is very, very helpful. And so I think what I do, my strategy for especially for these patients that have just everybody's got regulated inflammation nowadays, is I block them, I CGRP them, and I give them a round of steroids. Yeah. So I give them 20 milligram tablets, take half or whole until you find your happy place where your muscles no longer tender to squeeze. So that means you rebooted the pain, but you still got hot mess inflamed muscles, right? Because they're all pooling inflammation, because that's what CGRP and ACE2 dysregulation does, because everybody's had COVID by now. I need to talk about this with you guys because y'all need to understand this too. Because what happened with COVID, just very briefly, is the ACE2 receptor. That's the problem. ACE2 does more than just regulating angiotensin 2, which with its blood pressure effects and vascular permeability, which is really the big problem. But it's the brakes on the system. It's in the opposite of the yin and the yang with ACE1. And so it's part of the renin-aldosterone angiotensin system. But what it does is so much more than that. It's also key regulator in terms of inhibition with innate inflammation, the clotting cascade, adenine, which is regulating cardiac inotropy, and the kappa system in the central nervous system for pain. So people are having more clots, more
Oh my
dysrhythmias,
God.
right? Because of what it did to us. And what happened is it took it hostage, went in the cell. Now there's some conflicting data whether it still works or not. But it does, but it's brought into the cell where it's no longer extracellular, where it can do its job. And so what it does is it takes it out of the equation. So what happens is you have to get over COVID long enough to get back to where you were, you got it, to repopulate enough ACE2 to get back to where you were. But what it also did is it targeted places that are rich in CGRP, the trigeminal system. The nose was ground zero. And it just so turns out that CGRP and ACE2 are co-populated pretty well throughout the body, respiratory system, neurologic tissue, myocardium, sex organs, and joints and fascia. There's great studies which shows there's high levels of ACE2 and CGRP in the joints and fascia and tendons. And there's good studies out of osteo and rheumatoid. And so what happens is it creates sort of an autoimmunity, right? Because you still have circulating fragments of the spike protein going around in monocytes all over the body. And it just takes another virus to cause them to sort of re-up the game. It doesn't even have to be COVID again. It could be another virus because you're now immunosensitized to anything. And so what happens with CGRP is it creates a lot of IL-6, which is a cytokine that attracts inflammatory mediators. And also, it does a lot of things, but that's particularly one tumor necrosis factor alpha and all this stuff, which all hurt, but it also recruits inflammation. And what happens is you see this inflammation, particularly in places where there's no motion. So that's why patients hurt really bad in the morning, because there's vascular pooling caused by CGRP in places like their tendons and fascia. So it sits there. And so patients wake up with a rheumatologic pattern. That was me. I was waking up stiff and hurting all over, particularly in places that I couldn't rest. My necks, my jaws, my back, my feet. And what I found was really interesting for me is that I couldn't wear my wedding ring anymore. Still can't. You know why? A tourniquet. It's a tourniquet. So I wound up getting a trigger finger. I had to have a steroid injection in my finger so I could continue on using the left hand because it was getting so limited from pain and inflammation that I had to basically reboot it. And so one of my hand doctors did that for me, and it was impressive what it did for me. But what I've learned from doing this and doing the deep dive, going to rheumatologists myself and doing all this about, I talked to a lot of neurologists about this. They don't even get it. They don't even get it. The best they could come up with is I had polymononeuronitis, because what we know now also is going on is that the part of the viruses no one talks about is the nuclear capsid antigen. And guess what it mimics? Myelin proteins of oligodendrocytes. Yes. So we're seeing a lot of demyelination, both peripherally and centrally. And that's the scary part of this. So, yeah. So
more MS, more
right.
MS type symptoms. You're just totally describing a patient I just had today. She has balance issues. She's only had all of these issues since she has had COVID and long COVID. And she was told that she has MS. She was told she has fibromyalgia. She came in, she said, I'm having balance issues. I'm having sight issues. All of this has just come about since I was diagnosed potentially with long COVID. And
patients,
oh my gosh, do you see a difference in those vaccinated and those not vaccinated?
Right. There's good data on this. And I'm going to give you a follow-up talk on this. So first of all, yeah. So there was a study came out on COVID classic, essentially for unvaccinated patients. And they saw even mild cases had at 1 year demyelination, autoimmunity of oligodendrocytes, and there was evidence of it on PET scans and also on MRI. Loss of brain volume, white matter changes, and demyelination of changes in important places: thalamus, amygdala, hippocampus, sensory pathways. Because it's just following the networks. It's just following the wiring. And so what's happening is they found this in data. They see these are patients over 70, increased incidence of MS, Parkinson's, Lewy body dementia, and MS.
That's my dad.
Yeah, so the patients over 70, they got no play because every time you get the vaccine, you get a small amount of ACE2 antibodies. And every time you get more ACE2 antibodies, you get a bolus of inflammation and neuroinflammation, because that's what it does. It just relights the candle again, but in a very fixed sense. So it's important because these patients who have a high risk of a big hit, a catastrophic hit, they got to protect themselves, but understand they need to do all these mitigating things afterwards. And I haven't gotten my next vaccine booster because I don't want to hurt that bad. So what I've done personally for me to protect myself is nasal rinses, Neomed sinus rinses. And so what I've done is I've used Neomed sinus rinses with off-label uses of budesonide in them. So what happens is all the noses that are narrow are suffering, because there's no room in that shoe anymore. I've had to fix more noses the past 4 years than I ever have. And what I discovered by doing that, you don't put splints in those noses because they can't tolerate it. Just a source of nociception. So I put nothing in there, and I learned that from my own operation. I don't splint anybody in the past 2 years. And number two, I put everybody on budesonide rinses once or twice a day, depending on their exposure to snot. Right. So what you got to do is, keep your nose clean, essentially, because the nose is the middle child of the face. Nobody does this. And so everybody brushes their teeth every day, and their eyes are a problem. They go to the emergency room, but their nose, Claritin and Kleenex, and everybody's got noses that are outlived their warranty in the wrong place, around people, population density, and pollution, and in the wrong environment. So everybody's got a narrow nose. It's supposed to be in Northern Europe. What happened? They moved over on the Mayflower. There was no heat up there. They moved down to South Carolina, and now they're living where it's hot and humid past their warranty. They're only supposed to live to 38. And so here we are. All these patients in their 50s are coming in with mad noses, mad jaws, mad necks, because now they're lit up with inflammation and pain, and they can't breathe.
Have you thought about combining the viscous lidocaine with ozone or with stem cells from like PRF?
Well, these are all great ideas. They've also talked about actually putting Nurtec back there, and then there's a research study I was trying to see if I can get involved with, using an interesting device called nasoclean. I just happened to sit next to the lady that was the rep for it at the last meeting in Nashville, at the Embassy Suites eating breakfast. And I just happened to talk about migraines because I could tell she had a migraine. She was doing this, and we started talking. And she showed me this device, and it's a cool little thing that they use for just cleaning out the nose with some kind of antiseptic. I said, that'd be a great thing to stick lidocaine in. It's this little curlicue thing you stick in the nose, you look at the ceiling, you squeeze it, and they say, "Oh, we're working on that. We're making this because it's got a hollow bore in it. We're going to put Nurtec and lidocaine." You're screwing it up. Don't put the Nurtec in there. It's going to make it too expensive. So what you want to do is keep this Walmart brand. This doesn't need to be expensive. So everybody, even the person under the bridge on, crystal meth, needs to get out from under the bridge, put lidocaine up their nose to get them in a better space, because these patients really, they just need a better way. But there's no access to psych. There's not a better way. And so that's why at 58, with a 3-year-old at home, I'm taking time out of my life, because I think its potential in psych is good. So I want to tell you some cool stuff. So first of all, Rick Godley runs that site. He and I are working on a multi-center, placebo-controlled, randomized, double placebo-controlled trial using sphenopalatine for mid-facial migraine. And so what we're going to do is try and finally validate this thing we know works, because the neurologists, they're so stuck in placebo, it's not even funny. If you land it, this is cause and effect. We don't have to prove lidocaine works. We know it works, right? Yeah.
Yes,
So
absolutely.
right. So why I know it's cause and effect, because I know when I have it done on myself, when he shifts the lidocaine cotton ball over, 30 seconds later, oh, okay, I'm better. It's like when you put a little more local in there, now you can cut the skin with a scalpel. We know this works. And
Yeah.
so the whole thing is insecurity by Rick, because he's such a brilliant dude, but he's so beaten down by the neurologists, poo-pooing everything we do, because they look at us like we don't know what we're talking about as otolaryngologists.
Yeah, I mean, Charles and myself are TMJ centers with Dr. Stephen Almos, and we have about 70 centers that we're very involved in research. And having you meet him, we all do things the same way. Wouldn't you say, Charles? And it would be a great platform for you to meet him. And he has a great neurologist. His name is Wade Cooper. He used to be the head of Michigan State Oral Facial Pain and Headache Center. He's the one that taught me how to do a sphenopalatine ganglion block. And I've even had COVID people that had no sense of smell or taste. I did an SPG block with the sphenocath, and they got their taste and smell back like 10 minutes. And it was awesome. And I've worked with some other people that are more holistic, that talk about maybe using stem cells. And I don't know, Charles may even have some experience. I'm wondering about doing maybe some exosomes mixed with that. And I mean, I know those things are more expensive, but when you have a patient that has been they've seen 8 to 12 specialists, and everybody's saying, oh, you have MS, you have this. If you don't do anything, there's nothing I can do for you, because in 12 years you're going to be, or 10 years, you're in a wheelchair for the rest of your life. The woman I met today was like, so overwhelmed with the fact she's seen so many people and everybody's given her this terminal prognosis. And I'm like, you know what? I think there's a lot we can do. But I also am looking at doing sleep studies and getting the right and proper diagnosis. But I may call her and just say, let me try, these 2 blocks and see what we can do for you. Because if I can provide her that instantaneous release, and then I was wondering, as like with, and I know I'm talking a lot, that's my nature. I'm a
I'm really
Gemini.
enjoying this
All on.
opportunity.
But my thought is, oh, I just lost my train of thought, but oh no, as some of us are, I know that Cameron is a chiropractor, right, Cameron? Okay, so we work with these specialists and we have to. But that being said, Daniel, Clower, Charles, myself, Greg, we're all diplomates through different groups in oral facial pain. So my thought is, could we be able to bill this through medical as having that diplomate status? Because we're general dentists, but a lot of us are not practicing dentistry. We're only treating TMJ, sleep, all of this. And we're working very connected with chiropractors, osteopaths, ophthalmologists, all of these different practitioners and ENTs. I mean, you're an ENT, correct? Right, but you
Yes, we
have,
need a we need a virtual DMV for these patients, right?
yeah, I mean, I don't know when they decided that dentistry was not a part of the human body, when we have so much here that is like, look at how close we are to the brain and the neck and the jaw, they're all connected. I mean,
Plays such a huge role.
yeah.
Right, and it's an interplay. It's an interplay between some of this you can't control so much because some of it's what you get from your dealer, your parents.
Mm,
This is the shape
mm,
of your nose and the length of your jaw, but
right.
we have control over the length of our jaw by how we control the airway and control
Mhm,
the
mhm.
dentition through orthodontia growing up. So if we can get the jaw forward, if you got a narrow nose, that's key because then we can just control it by putting an anterior bite plane on there to keep your jaw from having to
Mm.
do all that work, right?
Yep. I mean, you're one of the few that this is like music to our ears. But I was wondering if you could also put in some of that long COVID research that you were talking about. I know it's above a lot of our heads. I mean, I did my
It's
major
not. You
in,
guys got this.
and I was a biochemistry major, so I can understand a lot of this. I
Mhm.
mean, because I was forced to do things, to understand that. And I didn't think that was going to be important, but what I'm now knowing is I'm using it more now than I ever did, understanding all the pathways.
Yeah,
But
chemical
thank
states
you
create
so much.
property traits.
Yeah,
Yeah,
thank you
this is
so much.
brilliant. I love what you're saying. As far back to the idea, I was triggered by one thing you told me that to think about something. What to put back there? Okay, we're talking about things. The things you mentioned were all like good ideas, but they're all expensive and hard to generalize. So I'm thinking things that you can make up out of the own patient's blood, like PRP.
Mm-hmm.
That might be something worthwhile doing because now you're talking about low tech, low cost.
Yeah.
What I'm really interested, Cameron, I'm glad you're here because my right hand person in this whole battle is with my good chiropractor friend Jeff Maxwell down here in town. He's got 3 badass traction machines. He's got red light therapy in there. He does heat and traction and tens, and all these patients go over there and I get them to go ahead and sign up. He's got a doctor over there working so he can make a chart up on them so that 6 weeks they can get the MRI of their neck and see what's going on so they can really have good answers. And then I know that he just gets massage therapist over there to work on their necks too. And
Yep.
it turns out my medical student is a DO. And so we're talking about
Wow.
all these ergonomic things. And so what we're doing is I've got on my handout that I give all my patients, I've got QR codes and links to neck exercises that I have my patients do in the shower for the last 5 minutes and turn the temperature up really hot after they've been in there for 10 minutes because that just put WD-40 on their muscles and tendons so they won't tear them when they're stretching these foreshortened muscles. And you're also employing, you're taking it from solid to solid by increasing heat to it. And then you're also getting blood flow in there. And finally, you're turning on the mitochondria, the mitochondrial enzyme glutathione synthase by near infrared light. And so near infrared light is low tech, high results. And it really,
Mm-hmm.
really works. So I got an infrared sauna at home and I love it.
Yeah.
And then the thing we really need is ergonomic rest for our jaws and our neck when we sleep. So what I'm wondering, and I'm told my son, who graduated from Georgia Tech, you want to get rich? Go create a memory foam ergonomic support system for you to lay in at night to lock your neck and your back into ergonomic ground zero, up and down. And then what you can do to make it even better is you can make it where it has a way to correct over time things like malcurvatures. And then people like our C-spine guys that do prolotherapy can actually start doing some fusing of some facet joints to actually then correct things in a way that's preservative. So I'm really interested. I don't know, Cameron, do you do that prolotherapy of C1, C2, or are you doing it?
We do prolotherapy as well, but more
I know
around
you
the
do.
jaw.
Greg was telling me all about that in
Yeah.
Louisville over some bourbon. I love the idea. So the whole idea is we got to figure out a way to live with our aging neck, because that's what's going to kick your ass at the end of the day,
Yes.
right? Because once you get to the point where your neck is not good, we got desperate measures. It's when things aren't working anymore, or you can't stand anymore. And at that point, we don't have good options. So what we have to do is figure out a way to reconstitute, spinal neutrality for these patients in a way where ergonomically they can protect their axial spine. And then the jaw comes along with it, because that's the other part we can't rest. Because it's working every breath we take. What's going to happen is it's going to wear out, and it's going to trigger pain, which is causing neuroinflammation, which is going to trigger migraines, which cause all the other stuff, which is causing everybody misery. And so these are really, really key components. The problem with this has always been classically a female disease. And that's the problem. So it never got enough attention over the many years. And so what happened is, this is a dramatic headache and never got enough care. Now we're stuck in a place where we know too much. Now we have what these patients need is a low basal estrogen. It's really interesting. There was a really good discussion on the Southern Headache Society meeting board about this. The problem is not everybody can take it. It can be neoplastic poison for some females because they have bad genes. They got BRCA. They got problems. If you put them on estrogen now, I don't got risk for cancer. So then you have to come up with a different answer. But I was talking to my good buddy as an OBGYN. We don't have good options when they can't take estrogen. I mean, we get to put them on Wellbutrin or so-called mimics the receptor, but that's a hot mess drug. It doesn't really work that well. And so it's really a tough problem because that's really the missing piece. Somebody can solve the problem that happens when estrogen doesn't play nice.
So what genetic testing do you do for the females that have this issue with that? Because I'm kind of going down the functional medicine realm, and I'm meeting a lot of female physicians that are either naturopaths or functional medicine doctors that have developed a way, even with women that have breast cancer, because they said there's only one study that actually proves that natural bioidentical hormone replacement therapy caused any of this. Only one. And these two women are regularly treating. One of them, her name is Michelle Sands, and she's treating women across the board with bioidentical hormone replacement therapy without having any negative results post having breast cancer and
I
whatnot.
agree with that. It's fairly lucrative, actually, that industry. And my buddy Jim Hubbard is, it's interesting that all the people on our fantasy football league team are all people that are involved in this. And we're talking last night for Monday Night Football, but yeah, this is an area where it can get expensive, right? And then there's certainly an aspect of it is we just don't know what the long-term impact of it is. And that's where it gets to be sort of a little risky, right? But
Right.
that is promising because that really is sort of one of the holy grails there, right? To find the way to master the what happens when our sex hormones of our sex organs are no longer useful. Because what's happening, we're seeing the results of bodies living beyond their evolutionary warranty.
Right.
We're
And
turning into a
I
collection of
just
worn out body parts.
absolutely. And they've done so few studies on females. And there's a neurologist from, I think, England that said that she's been checking the neurology, and when a woman is postmenopausal, their brain shrinks almost a third. And there's so many things that we're not even looking at that we don't understand, yet females are the ones with most of these problems, right? And isn't it due to the estrogen receptors? We have more estrogen receptors. We feel more pain. Guys don't feel this pain until they're pretty destroyed, you know, when we see them. And then it's like,
Right.
okay, how reversible is this? It's not, you know.
That's what I told my females after they reach past menopause. Okay, congratulations. Now you have a male brain now. You're going to be able to
Yeah.
tolerate things better. But
And
this is
you're also equal as far as sleep apnea and all the other freaking
and
issues.
cardiovascular risk, right? Yeah.
Yeah.
All the stuff they used to protect for. So yeah, man, solving that problem. But the good news is the NIH came out recently is that they're trying to open up the IRB's shackles on doing research on kids and on pregnant ladies. Because that's the beautiful thing about blocks. I've got a cadre of pregnant women. I've helped them with their hyperemesis. Had a patient come with zoster, blocked her, she was better, and
Oh
her
yeah.
hyperemesis got better too. And then, Bell's palsy. She had pain in her. Actually, her
Mhm.
face started working better, like right then. So
Yep.
something you can try on. So these are cool little things. It's like every time you do it, you see a new thing. Oh gosh, it works for that too. And I'm
Mhm.
really curious to see what it would do for the Parkinsonian symptoms.
My father has Parkinsonian symptoms, and he has for a year and a half. He ended up in the emergency room with RSV. He has pulmonary fibrosis, and he had pneumonia. And basically, he doesn't listen to me, but now they're saying, oh, we think you know what they want to do? They want to take out his salivary glands. They want to do all the he has a mucocele in his sinus. Oh, we need to get in there and surgerize that because that could be causing it. And they did Botox on his salivary glands today. And I'm like,
Right. Has he got hypersalivation?
yes, yeah.
Hmm.
Because when I started seeing him, what's his name? The guy that was in the Back to the Future. He has Parkinson's.
Bugs.
Yeah,
Am
Michael
I?
J.
Am
Fox. My father has got that look to his face. And then he was
got the mask?
hypersalivating. He had the tremors. He's had sleep apnea for years, but he doesn't believe me. And he's a military man with PTSD and was exposed to Agent Orange. So he's got a whole boatload
Block
of
him.
things.
He's probably got high parasympathetic tone.
Oh
Block him
yeah.
with his SPG.
So
And the other
that's what
thing
I'll
you want
do.
to do, the other thing happens is they don't swallow spontaneously much. Parkinsonian
Absolutely.
patients start to lose bulbar spontaneous swallow,
Yes.
and
Yes.
so that's part of what happens. And they get that voice, and they get the inability to clear nasal secretions because their palate gets
Yep.
sluggish.
So they just put him on Afrin and a bunch of other things. And
Where does he
they said
live?
he lives in New Hampshire. He lives in New Hampshire.
Ooh, okay, he's not too.
You know someone? Because they want to know. They haven't seen an SLP. He lost 25 pounds in the last since March. And he has a difficult time swallowing, of course, because of all he doesn't have his first appointment with the neurologist until Halloween.
It's the nature of the beast. Yeah, I would block him. If
Okay,
not, just give him some.
I'm gonna have him come in and
Block them
I
up. Do
will,
the whole array. You got nothing to lose. And in the
right,
end of the day, I think this Botox on the salivary glands. I think they're just missing the point. I don't think he's probably got hypersympathetic tone. He's got poor
yeah,
swallowing, so his
yeah,
saliva can't go anywhere. And if he's got a stopped up nose, his mouth's open all the time. And
yeah.
so it depends. Yeah, so that's part of what's going on. I think it's sort of
So,
misunderstanding
but
the
now
condition.
they're not gonna know because if I get him in and block him, he just had Botox today, so they're gonna say, oh, it was our ENT that Botox his salivary glands. We're good. But
Maybe.
that's
I mean,
fine. That's fine. I
and
mean,
it's not going to hurt him. It just might make his mouth dry
yeah.
because it's
Okay,
going to be open
thank you
anyway.
so much. I'm sorry I dominated. We didn't even get
No,
anything
this is
from you,
no, this is what
Cameron
I'm here.
or Charles.
I want to hear you guys talk. I want
Yes.
to shut up myself and
Okay,
hear from. I want to learn from you guys.
Cameron or Charles, I'm gonna zip it.
Dr. Abrams, thank you so much for the lecture tonight. It was really great. I like the approach to be able to target the masses with a cost-effective way of treating those symptoms without breaking the bank, because a lot of people cannot afford this type of treatment. And I have taken some courses from Barry Glassman, who is another dentist, who talks about doing the sphenopalatine ganglion injection paired with greater occipital and lesser occipital injections. And he also had the neurologist who's in charge of the head and neck department at Harvard lecture on injections, and they do inject 5 cc's of anesthetic in the back of the head to distract and separate the tissues to provide a bolus that will also help those headaches not recur um, in 3 or 6 months. So they have studies on those things I could share with you if you're interested. There's a lot of information on those headaches, on treating headaches with injection. They teach us how to do a sphenopalatine injections with a 2-inch needle from above the coronoidal notch, angle downward, anteriorly.
Zygomatic approach.
Yeah, super zygomatic approach, and that seems to be pretty effective and a painless way to address the SPG. In addition to that, we also, as dentists, can also address the cranial, the trigeminal nerve intraorally if we need to. But for the most part, they talk a lot about doing an auriculotemporal injection along with these sphenopalatine injections paired with the greater and lesser occipital injections.
I will use the great
Mhm.
auricular or something a lot. Yeah, about
Yeah.
5%.
So thank you so much for taking the time. We really enjoyed your lecture, and we love to hear you speak, hopefully, in the future at one of our meetings. Yes.
Absolutely.
Yeah, well, this is great. However you block the patients is great. It doesn't matter how you get there as long as they can get to land the airplane and do okay with it.
And we'd like to also get more knowledge from you on all those neuro pathways that you seem to have a better understanding of than most dentists do. So yeah, we really relish into that. We relish that language.
It is cool. I'll tell you what's really the coolest thing. If you go onto the AMD website and let video, it's on my thing that Rick Godley put together. He should win like some kind of award for it. It's brilliant. And it's like watching like a Star Wars ride. And they're going through these different pathways in the brainstem lights. So well done. And I can't stress. I mean, the poor guy, he's retiring in about 9 months. And so this is like he and I are trying to collaborate. And I'm older too. We're trying to get this you get to the best of your ability when you're at the stage in your career where you still got enough juice in
Yeah,
the tank to try to get this out there as the last salvo so some young people can take the ball and run with it because
yes.
we're all sort of getting a little older in our tooth here with this process. And Kim, you look young, but anyway, but
I know, I'm almost
hey,
60. I'll be 60
and
soon.
in the camera, look, he's looking like a young guy, dude. But me, I'm a fossil. So, I'm a good guinea pig for this because I have all the problems. I have the problems my patients have. So, you know, it
Mhm.
becomes humbling, but it's very enjoyable to liberate your comrades.
Yes, and we really do enjoy collaborating and sharing knowledge with each other, and hope that the future
With this
generation
again.
will benefit from
So,
that knowledge. Yes.
so what I can do is I can take the part about the COVID stuff and I can make it into a really short thing, and we can reconvene and get everybody together so I can sort of up you to snuff in that. And what we can do is maybe let you guys sort of bring something to table to discuss here too, because I think, I'm really interested in C-spine stuff because I really think that's where we have the missing. That's the ultimate.
Absolutely.
That's like the estrogen. We can fix the C-spine
Absolutely.
thing.
With me today,
That's where we all
Cameron,
the head forward
my
thing. Yeah.
yeah, my patient today had a kyphosis of the neck. And in addition to all these other things, and I was like, oh my God, I need a chiropractor or PT, I need ENT, I need myself. I was just like, she needed everyone. And she's
Yeah.
been so mistreated and misdiagnosed for since 2022, 2 years. And, there was other issues her whole life, but I mean, it just was wow.
Well, I'll be honest, most chiropractors don't have a good understanding of the neck. That's why there's a specialization within chiropractic that focuses on the craniocervical junction. And even then, the people in that band still don't have a great understanding, which is, Dr. Larson alluded to it. I am younger. I turned 36 this month
Woohoo!
or last month. Thank you very much. But I have made it my mission to try and fill some of the gaps with what we've seen in my profession, at least. And so, you said kyphosis. That's actually very common. The research is inconclusive about whether that matters or it doesn't. It matters always on a long enough timeline, right? So we know with Wolff's Law and how bone basically remodels under pressure over a long enough timeline, that kyphosis is going to cause a real big issue. So the question becomes, how do we fix it or how do we improve it? Doc, you alluded to maybe a pillow. There's a pillow on the market right now that has an orthotic in it. And when you lay back, there's a small opening, and it essentially opens your airway, puts a curve in your neck. We've used that for certain patients. It's hard to get used to. I used it for 2 years, but there are things that are happening within the realm of neck that I think are very compelling. But still, unfortunately, the evidence is extremely limited with regards to consistency because every neck is different, and up to a certain point. And I don't want to take too much of your guys' time, but when you see a kyphotic neck, you actually want to ask the question, so it's kyphotic, but does it move correctly? Because movement is life. We know that. Movement of the jaw, movement of the eyes, movement of basically everything. And so sometimes that kyphotic neck can actually be fixated. So there's a difference, at least orthopedically, between a neck that doesn't move, right? So if you have them tilt their head backward, what you would see on like an extension x-ray or a lateral x-ray and extension, that neck literally is fixated. So you're seeing hypermobility in the craniocervical junction. That is going to create a shitstorm with regards to nociception, right? Aberrant mechanoreception, aberrant proprioception into vestibular nuclei, into all of those brainstem centers. You said reticular activating system. And now, again, my group is missing the mark of they're just like, oh, we just need to manipulate. No. Maybe, but usually no. It literally takes, so for example, I actually have a cone beam in my office. So I use cone beam CT. When you take an image in extension on cone beam CT, you'll see things you've never seen before. I've never seen it in the literature. We're hoping to publish a couple things with a couple orthopedists, but you start trying to understand how the spine moves, you end up with more questions than answers. And as far as I can tell, not many people have. I'm not saying I have the answers. I'm trying, but the neck is no man's land. We don't have it figured out, and especially craniocervical junction. If you have patients who have had motor vehicle injuries or motor vehicle accidents, and now they potentially have laxity of the ligaments in the craniocervical junction, stem cell, there's only one place in the country that does stem cell into the alars and the transverse. That's still experimental. So we're all in the same boat. There are things that some folks are doing that are working. We maybe understand why, maybe don't. Doc, you had mentioned laser, cold laser. I have a device, Vilite. So it uses transcranial photobiomodulation, and it has an intranasal probe. The research behind this company, Harvard, Yale, the VA, PTSD, veterans, neurocognitive, Parkinson's, all of this stuff. It's fascinating what we can do right here.
Because red light penetrates 8 centimeters into the body. And so that's the nice thing about it.
So Charles and I use many different laser therapy.
Yep.
And what you just said about hypermobility, guess what? My patient today had, she's like this, all flared when I told her to put her, and then there was another thing that came to me with her. She has long COVID, and the way her brain was processing things was reverse. So I said, put your hands like this, and she put her hands like this. I said, put your arms like this. She put them like this. So, and she's having some ophthalmic vision issues, balance issues, gut issues. And I was like, but everything that I asked her to do was the opposite. So I didn't understand that, but it was like so unusual. I was like, okay, can you put your arms like this? And she would be like this. And I had to physically put her arms in the right position. And then I said, okay, put your arms straight out with your palms facing down. And she did up. So her brain was processing the opposite of kind of what I was asking. And
Was there a tremor?
she did not have a tremor. And one side, her left side, which as you were saying, Mark, she has a more, she's more compromised nasally on the left side. And she was more hypermobile though on the left side.
Mm.
And she's an upper, all of these, all the accessory muscles, she's an upper chest breather. But it was just like, some things happen for a reason. So I'm sitting here going, she's telling me about her eyes, her vision, her balance. She's had issues with balance. So I tried to have her, I'm doing all her cranial nerve exams, and I say, because I keep her eyes closed when I'm doing these exams, and I keep a stick in between her teeth so that the trigeminal nerve is not on when I'm assessing I have them close their eyes and I have them put a stick between their teeth. So the trigeminal nerve is not activated and the eyes aren't activated. So I can individually test all of the different nerves. And so I said to her, I said, I'm going to have you stand up. I'm going to have the stick between your teeth, close your eyes, and I want you to stand on one foot. And actually, when I did the test just to check the sway, she was all over the place with the sway with her eyes closed. And then,
problem,
yeah, so she was like, I was like, okay, and she said, I can only stand on one leg if I hold you. And I said, no, I'm gonna hold and make sure you don't fall. And it was interesting because then what she did, and she doesn't do yoga, she actually lifted her foot up but stabilized it on the calf of her other leg so that she could balance, but she still was wobbly. But I said, do you do yoga? She goes, no. But I didn't understand. But she's always been hypermobile. She's never been tested for Ehlers-Danlos syndrome. But there were so many interesting things. And she was talking about all of this happened post-COVID. But I'm going to stop talking. But you guys just keyed me in on so many different things with this patient.
I
That's
got your
interesting.
thoughts on that real quick.
Yeah.
Go ahead,
No,
Cameron, please.
Dorsal column, cerebellum, like, I mean, maybe if there's some sort of peripheral neuropathy or, like even a sensory issue, blood vascular issue, if she's deconditioned in that lower extremity. But Romberg's for sure. That's interesting. When you close the eyes, obviously, when you take out the neurovisual sense, that's a little bit more proprioceptive in nature, right? But even then, it's seated versus standing, obviously bringing the ankles, the knees, and the hips in that lower extremity, at least in my experience, from a vestibular standpoint, that kind of changes how your brain senses. That's interesting. That's very interesting. Ehlers-Danlos is we haven't even scratched the surface with
No.
regards to
And we
hypermobile
see so
stuff.
many
Yeah.
of them.
It's
It's
crazy.
interesting because my student, actually, the one that's the DO, she has Ehlers-Danlos and she has migraine. So we sort of geek out about this because she's got a lot to add to that. And also, she's very interested in female medicine. But to the point about your patient, I think it's long COVID. And so what's probably happening is I think she sounds like she's having thalamic demyelination. So she's getting crosstalk on nerves that are closely approximated. Now, the thing is, what's happening is they got slow processing speed too. And so if you were to do a block on her, I would be interested to see what would have happened afterwards. Because a lot of these patients with these symptoms, even if they have bad proprioception and bad glove stocking, they actually then can actually function better after a full block array because now it's no longer going through a bandwidth hog called migraine. And so now it's got a faster processing speed to at least use bad information now being traveled from bad input, from bad feet, bad lower back causing cauda and all the proprioceptive problems. And so that's what I found that helps these patients. But with her, the interesting thing that you told me there is that, first of all, that was very fascinating about this whole thing there. I still not sure I understand. I'm sure she's had an MRI, right?
I know she hasn't. I don't know that she has. I
Oh
have to.
gosh,
I
she needs
just
an
met her
MRI
today.
desperately because it
I
sounds
have
like
to.
she's got. I mean, it's certainly possible she could just have MS, or she could have been
Well,
triggered
no,
into
yeah,
an MS flare.
she did because the guy that told her she had an MRI, she was evaluated for. I mean, the guy that told her that she had MS, she was evaluated, and they had no positive signs on the MRI of MS.
And the problem is MRI is not diagnostic necessarily.
Right.
You got to do a series and you got to follow the symptoms. And it's a hot mess MS is, right? And no one's going to do a tap on these patients always looking for major basic protein. So what you got to deal with this now. We got a clinical diagnosis with not a lot of physical findings, and even the MRI findings aren't compelling because all these patients have demyelination for God knows what anyway. They have migraines, right? They're going to have white matter changes as well. So there's a difficult case right there for you. And here again, if you could use the block arrays just as a diagnostic tool, just to take that out of the equation, then now you have what's left is now what's in the brain, right? Or the other things that we can't really fix easy, like bad wore out, spinal cord, and peripheral neuropathy here again, which we don't have ways to restore the sensation. We have ways to more sort of modulate the pain with, GABA, but it's not really any good tools for those things. And so that's why we've got to figure out a way to keep people from getting to that point where they become, immobile.
How do we treat
Tonsillar ectopia.
What's
Do you know
that?
what that is? Tonsillar ectopia.
Tonsillar ectopia.
So it's Chiari. So basically
here,
of cerebellar tonsils. That the visual stuff for sure. Actually, a certain level of Chiari will create in dark. If you like VNG or VOG goggles, you can potentially see a little bit of a vertical oscillation, or in some cases nystagmus. But I mean, you said vision type stuff. Like there's some obviously neuro stuff there.
Yeah. Oh,
you would want to see what's going on at that foramen. Is there crowding? Is there basilar invagination? Is there a cranioaxial or craniocervical angle that is too steep or too acute, right? And so now we have maybe some medullary compression, maybe a pannus on the back of C2. All of this stuff that personally I see in my practice doesn't get missed, but the radiologist will look at it and they'll be like, man, everything's fine. But if you talk to the Chiari folks, the actual like neurosurgeons, they've got a great conference, by the way, asap.org. The number one thing that these folks look at is basically tightness. And they're kind of they're not necessarily in agreement on like cine flow studies, which I think are super cool. But essentially that CSF flow going through the foramen magnum, if it's choked, you're going to have very similar symptoms to that patient. Balance, vision, all of these things that get commonly missed unless the MRI has a graded Chiari, like a Chiari 1 or Chiari 1.5, which pretty much no one is going to miss. But right now, I think some of these folks are trying to reclassify Chiari to almost a Chiari like 0 or 0.5, because certain patients, again, if you look at that anterior portion of the spinal cord, if you look at some of the like cistern spaces, if it's jammed up there, ain't no flow getting through. And unfortunately, one of the only ways that you can find that out is by putting them upright, doing a CSF flow study, which not many people do, or doing them recumbent and doing a cine flow, which, again, some of the evidence is like, it's better upright, it's better recumbent. This stuff gets missed a lot. Again, not saying I have all the answers to that, but we've seen so many things, balance issues, and these visual issues, which if you look at Chiari symptoms or tonsillar ectopia symptoms, it fits that Venn diagram. Headaches too. I see a lot of headaches.
So would that occur just post-COVID? Because she didn't have these symptoms prior to having COVID.
Neurogenic inflammation.
It's basically the whole
Yep. Brain's on fire.
Innate inflammation in the neuroinflammation. But the combination is she was that Ehlers-Danlos patient.
No, I don't know if she is. I saw her today.
Right. If she's hypermobile, you got to consider that she's hypermobile in her neck. And I want to ask Cameron this question. So the more the patient gets this cross-ex head forward position, is that putting more traction on the base of their brain stem coming through the foramen magnum? The more anterior, the more this anterior head forward position, it seems to me what it's doing is it's pulling down on the brain, and that's going to cause two things. It's going to cause
in theory, yes. So right. The dura getting traction just a little bit, and potentially the dentate ligaments that sit horizontally at the level of the craniocervical, like C1, C2, sometimes down to C3. What I saw, or what I think, and I'm seeing this more and more, is just like you said, Doc, It's this. And it's basically it's the compression of the craniocervical junction. It isn't necessarily, at least we can't see it on imaging, right? You can't see like dural stretch on an MRI, at least not on like a 1.5 or a 3. I haven't seen it. But that compression of space, that compression of the neurovascular structures back there, so like the venous plexus that sits, what's it called? It's like the foramen magnum venous plexus. It sits right there at the base. If things get jammed down, we have all of these weird symptoms vascularly, POTS type stuff, orthostatic type stuff, and then again that compression and the increased tone, increased firing of muscle spindles at the base of the skull, right in the suboccipitals, which now feed right into that cerebellum, right into that vestibular nuclei, and now they're dizzy. I think this is such the whole tech neck thing. I don't think the tech neck is as big of a problem as we've made it. I think the forward head posture and then this is the problem. But like someone just kind of bringing their head down, that's not great. But that compression at the CCJ, I think that's a bigger problem.
So I have full records I took today, a full CBCT, photos, all of this.
Yeah.
I shared that information. I got permission to share that information with you guys. Would you give me like a little input?
I'd love to.
And Dr. Abrams, if there is the demyelination with post-COVID, what do you treat that with? How do you stop the demyelination process? You can't, right?
That's the thing. Now there is that. Now, did you watch 60 Minutes about a month and a half ago about that guy from West Virginia?
No.
That is cool what he's doing. This guy that's using stereotactic ultrasound on the brain, and they're using for Alzheimer's, the typical Alzheimer's drug. That problem is the blood-brain barrier, right? You can get it into the right place by stereotactically using ultrasound to actually break down the blood-brain barrier, then give the IV drug, and then it actually gets there. They did PET scans 3 months later, and guess what was gone? PET evidence of, all that tau and, and all the, the amyloid. And so that is incredibly promising. So I think we're sort of at a crucial point. So what needs to happen is sort of what I consider sort of a neuropsych Manhattan Project. Because right now we're at a crucial point where we need to be able to synergize and get these tools together, because our entire planet is losing its collective mind. And what we really need is a reset button for everybody, because everybody is very much serotonin and dopamine depleted. So they're highly triggered, highly, because everybody's just, we've lived long enough that we have the luxury of entertaining ourselves. So we became dopamine addicts by just entertaining ourselves. And so our low basal dopamine's part of it, low serotonin part of it. So everybody's triggered and happy, and now they're hurting everywhere. Their glutamate's up. So they're, depending on which hormones in their brain, they either punch things or terrorize people. Is like our teenage kids, because they can't get out of their own way, because this is what's happened. We've come the opposite of the Mediterranean 100-year life, but we're living a long time. And so we've got to solve this problem. And so that's why collaborating, getting these ideas together and bringing it full circle, because we got some pretty cool stuff. That dude in West Virginia, he's brilliant. I talked to one of the guys that was at medical school there, and he said, that guy's ridiculous. He's just so far ahead of everybody. But those are the kind of people that need to get together, people which have maybe a little bit of altruism and maybe a lot of money, like somebody like Bill Gates or something, to get this shit together so we can actually win this game, because we got the time ticking. Things are happening on our planet that if we don't get our collective shit together,
we're not going to have a planet. Yeah. But the thing
between
is,
AI and everything else, right?
I mean, we have so many people with leaky syndrome. We could IV this ultrasonic stuff in there quick, because they have a leaky brain, leaky heart, leaky gut. We may not
and the gut's a big deal. And that's another thing on the long COVID stuff. What happened is it causes a low absorption of tryptophan.
Wow.
Because of what it happened with interferon 1 from the virus and CGRP betas in the gut. And so what happened is it changed the game by causing a change of your absorptive characteristics based on microbiome, and also based on the effects of interferon 1 on tryptophan absorption. So not only are we having pain bringing our serotonin down, we're having a low pool in these patients.
Oh
So
my
there's a
gosh.
lot of shit going on that's
Wow.
synergizing in a bad way to make all of us feel like shit.
Mm.
And so,
Well,
and
you
that's, and
guys
this,
just incited me. You just set my dopamine
and
and
this
all
is the
my
worst part. No one cares anymore. Only 6% lose smell with COVID with the new strains. And what happens is no one cares anymore because it's so 2020.
Oh,
And nobody
oh.
does nasal hygiene. And so here we are. So everybody get a Neomed bottle and learn how to do it. I'll teach you if you need to. Rinse
Hey,
your nose.
we are on the nose, and we have been for probably how many years? Since 2015, we've been talking about clearing the nose and getting that. But our ENTs don't want to listen to us. What do you mean? We want to go in there and surgerize and do a septoplasty and all this stuff, and it's like now we have all these empty noses, and the problem's even worse.
I'm aggravated with my own specialty too. It's all we can do to get them to pay attention to migraine. It's like trying to have your kids eating spinach. Yeah. Yeah.
Well, I
They
want
all
to
want to
thank
just send them to
you.
me.
I want to
Huh?
thank you. You guys are awesome. I think I haven't even eaten yet, so I better go eat. But
Me too.
I'm like, oh, but we
Everybody feed their
appreciate you
brain.
so much. I know we need
You're
to feed our
welcome.
brain. Thank you. And
Yeah.
Thank you, Dr. Abrams. Thank
yeah,
you.
Thanks,
well,
Alex.
We'll
yeah,
get
I
back
think that,
together and I'll
yes,
hopefully have something more
absolutely.
positive to say at that point. But
Oh, you gave us so much, right, Charles? I
Oh
mean,
yeah, it's so much information. I love it. I mean, I could
I
have sat
just
together
like,
all night long.
I know, I have all these pieces of paper I've been writing on. I'm like, what the
yeah,
hell? Oh my gosh,
yeah
you're speaking language.
we're just people that drive our families crazy talking about this stuff, right?
Oh yeah,
You
we could
got,
get together and
yes,
just talk about all this stuff all night long.
Yeah, thank
absolutely.
you for sharing.
Yeah.
Yes, thank
It's
you
been
so
great
Thank
talking.
you.
Y'all are my people. I
Have a good
appreciate it.
night.
Have a good
All
night,
right,
and
bye.
we'll
Thank
Good
you.
night.
stay tuned. We'll do it again.
Yes.
Absolutely. Have a great night.
All right, bud.
Bye.
Thanks, man. Peace.